Hello guys, this is Dr. Midhun. I'm doing super specialty in critical care. Today I have come up with a very new video. Uh, from today, we are discussing postpartum complications, the critical care aspects. So without wasting much time, we'll go on to the video. We'll first discuss about postpartum hemorrhage. So today's topic is postpartum hemorrhage. So this is a very brief description about postpartum hemorrhage. Primary or early PPH refers to PPH occurring in the first 24 hours after giving birth. Secondary, late or delayed PPH refers to PPH occurring from 24 hours to 12 weeks after birth. So, the American College of Obstetricians and Gynecologists revised their definition of PPH in 2017 according to the following: cumulative blood loss more than 1 liter, or bleeding associated with symptoms and signs of hypovolemia within 24 hours of birth process. The criteria apply to both vaginal and cesarean birth. So these are the causes for postpartum hemorrhage. The 4 T's. Tone. First one is tone. If there is abnormal uterine contractility because of uterine atony, over distension, and muscle fatigue, the risk factors can be prolonged labor, multiple gestation, oxytocin augmentation, polyhydramnios, or it can also be because of inflammation due to infection, like chorioamnionitis. The second one is tissue. It can be because of placental complications like placenta accreta, placenta integrata, percreta. Uh, Also because of retained placental products. Risk factors include multiple gestation. It can be because of placenta previa also, because of placental blockage of cervix. Then placental abruption can also be a cause. Another one is trauma. So physical injury can cause laceration of cervix, vagina, or perineum if it happens. The causes include malpresentation and instrumental delivery also. So injury during C-section, any uterine rupture that happens, previous trauma, gland multiparity, previous vertical uterine incision can also be causes for postpartum hemorrhage. The fourth T is thrombin. So if there are any congenital coagulation disorders like hemophilia, von Willebrand disease, acute coagulopathy like DIC, hyperfibrinolysis, any pharmacological anticoagulations, the major coagulopathy independently associated with PPH is low fibrinogen levels. So now we'll come on to the potential interventions for the treatment of postpartum hemorrhage. These are the pharmacological interventions that we are discussing. The first one is oxytocin, that is a first line drug. 10 to 40 units in 500 to 1 liter of normal saline infused at a rate sufficient to control atony, or 5 to 10 units IM can also be given. Then tranexamic acid, it's an adjunctive agent. 1 gram is infused over 10 to 20 minutes. If bleeding persists after 30 minutes, a second 1 gram dose is administered. Ergot's second line treatment, methyl ergonovin 0.2 milligram IM or ergonovin 0.2 milligram IM every 2 to 4 hours. Carboprost, that is also second line, 0.25 milligram IM every 15 to 90 minutes up to 8 doses. Misoprostol, 400 to 800 mics sublingually as a single dose. Recombinant human factor 7A, it's an adjunctive agent. If other treatment modalities are refractory, 50 to 100 mics per kg. It is preferable to start with a lower dose, 40 to 60 mics per kg. The dose may be repeated once in 15 to 30 minutes if there is no response. Additional doses are unlikely to be effective. So this is the maternal early warning criteria. Systolic BP going less than 90, or if it is more than 160. Diastolic BP more than 100. Heart rate less than 50 or more than 120. Respiratory rate less than 10 or more than 30. Oxygen saturation and room air at sea level less than 95. Oliguria less than 35 ml per hour for more than 2 hours. Maternal agitation is there, confusion, unresponsiveness, patient with preeclampsia reporting a non-remitting headache or shortness of breath. These are all early warning criteria of PPH. So any mother who is having these clinical signs, or having any agitation, confusion, or unresponsiveness, or all these clinical signs, we should take them as a warning sign and be prepared to manage an emergency. So goals in the management of PPH. So restore and maintain adequate circulatory volume to prevent hyperperfusion of vital organs. Second one is restore or maintain adequate tissue oxygenation, reverse or prevent coagulopathy, eliminate the obstetric cause of PPH. So intrauterine devices such as a balloon tamponade or low-level vacuum to facilitate uterine compressive forces. Then invasive procedures like uterine artery embolization or surgical intervention until hemorrhage is controlled. Traumatic hemorrhagic lacerations are controlled surgically. Topical hemostatic agents and tissue adhesives. Delayed hemorrhage retained placental tissue is usually detected by ultrasound and removed by curettage. Placenta accreta spectrum generally requires hysterectomy. So we'll come to the classification of blood loss and the clinical signs the patient can present with. If the blood loss is up to 750 ml, it is class 1. So it is only like 15% of blood loss. Pulse rate can be less than 100. Blood pressure can be normal. Pulse pressure can be normal or increased. Respiratory rate in the normal side. Urinary output is also normal. CNS or mental status can be also normal to slightly anxious. We can manage the blood loss with fluid replacement. So when it comes to class 4, blood loss is more than 2000 ml. So that is more than 40% of the blood loss. Pulse rate can be more than 140, blood pressure can be decreased, pulse pressure can be decreased, respiratory rate can be more than 35, urinary output can be negligible. So patient can be confused or lethargic. We have to manage the patient with a lot of crystalloids and blood transfusion. So this will give you a gross idea about the massive blood transfusion protocol. So patient at risk for uncontrollable bleeding or trauma team activation, start blood drawn. So we have to send it to the blood bank. Typing and cross matching should be done. Then we have to send to the clinical pathology and send the then do the DAC panel. CBC and APG should be done. If there is any immediate need for transfusion, we have to go for transfusion. If there is no immediate need, conventional resuscitation ongoing evaluation will be fine. So, so if there is an immediate need for transfusion, in adult patients more than 50 kg, transfuse 2 units of O negative blood, transfuse 4 units in 1 hour, anticipate total requirements greater than or equal to 10 units. For if it is in pediatrics, patient less than or equal to 50 kg, transfuse 0.1 units per kg O negative blood, anticipate total requirement greater than 1 unit. If the patient is needing MTP, activate MTP. If patient is not needing MTP, conventional resuscitation and further evaluation at intervals will be necessary. If the patient is needing MTP, activate MTP with the initial adult MTP pack of 6 unit PRBCs, 6 unit FFPs and 1 apheresis pack of platelets. Activate MTP with initial pediatric MTP pack in pediatric patients of like 4 unit PRBCs, 4 unit FFPs and 1 apheresis pack of platelets. Initial lab results, we have to send for the initial lab result. We have to check for the initial lab results. If the INR is more than 1.5, give 4 unit FFPs. Repeat until INR is controlled. If the platelet count is less than 25k, give 1 apheresis pack to increase the platelet by 25 to 50k. Anesthesia or nursing. Monitor the CBC, PT, PTT, fibrinogen every 30 minutes. Clearly document all the products given and lab results. If the lab results are not within normal limits, we have to repeat the initial MTP pack. Tranexamic acid can also be given to stop bleeding. Consideration for the use of recombinant factor 7A can be given after 2 to 3 rounds of MTP packs. If the lab results are within normal limits, anticipate ongoing bleeding. So if there is bleeding happening, we have to repeat the initial MTP pack. If there is no ongoing bleeding, deactivate MTP criteria and blood bank to check on the team if MTP has not been deactivated for a while. So these lab reports has to be repeated. DAC panel, CBC and APG has to be repeated every 30 minutes if there is ongoing bleeding happening. So role of hysterectomy, severe bleeding due to diffuse placenta accreta spectrum or a large uterine rupture which require aggressive surgical management. Hemodynamically stable patients with persistent bleeding after initial therapy, arterial embolization is an effective treatment. Extracorporeal membrane oxygenation management for the management of severe PPH and amniotic fluid embolism. So this is all about the brief description about postpartum hemorrhage. Hope you have got some knowledge about PPH from this video. We'll come up with a new video in the next session. Thank you so much, guys.